Today's topic is fracture around ankle. We will be discussing today a complex one and is asked in the examination, not very commonly, but it can be asked. So we will understand a little bit of the clinical anatomy. Remember when we talk of the ankle joint, we talk of the two joints. One is the true ankle joint and another is sub-talar joint. The true ankle joint, we know it contains tibia, the medial wall of the tibia, the fibula and the talus. The sub-talar joint made of the talus and calcaneus. Now the movement that is occurring at the ankle, for the tibiofibular joint, it is only plantar flexion and dorsiflexion. And at the sub-talar joint, it is inversion and eversion. Inversion and eversion, it is easy to understand. It means the sole of the foot can be made to face inward or it can face outward. Inward is the inversion, outward is the eversion. Inversion injuries, they are most common ankle injuries. And why so? We have read in the books that it is most common and that is correct. But why it is so? And the reason is there are two anatomical variations. One is the medial malleolus is shorter than the lateral malleolus and thereby allowing the talus to invert more than talus can invert. And the second is the deltoid ligament is a very strong stabilizing ligament on the medial aspect and it offers very strong support. Whereas the lateral ligaments, they are not so stronger and they support but not like the deltoid ligaments. But eversion injuries are not unknown and occur with a very large force applied over the ankle. And then there will be substantial damage to the bony and ligamentous structures which support them, and usually the joint stability is lost. The side effects of the fracture around the ankle is talus fractures commonly occur in the snowboarding trauma. A calcaneal fracture comprises of the inversion and eversion of the ankle, and surgical complications and prolonged rehabilitation are usually common in the calcaneal fractures. Older patients with ankle fractures experience more long-term complications than the younger patients. The complex open fractures with the substantial soft tissue damage, definitely they have a very worse prognosis than isolated closed ankle fractures. The isolated or non-displaced lateral malleolar fractures have a very favorable and good prognosis and they heal remarkably well without any side effect. Let's start now with the history taking. Usually we try to know the direction of the torque force which has been applied over the ankle and the foot. That should be known to us. And also, whatever the position of the foot at that time, it helps us to predict the nature and severity of the ankle injury. And many of the patients, they may recall the event, but more often they cannot depict the exact manner in which the injury has occurred. Sometimes history of the prior trauma is important for a doctor to know because there will be antecedent laxity, instability, and then there will be likelihood of more of the trauma which has been caused to the patient at the present time when we are taking the history. And it helps us to understand the radiographic abnormalities, and we will not be misinterpreting them as an acute event. Probably they are old ones. And of course, the chronic medical conditions such as diabetes, peripheral vascular disease, and metabolic bone disease, they affect our way of examination, and they also affect our treatment plans. Chronic medication also is important for us to know. Say, for example, if somebody is taking the steroids for a longer time, we know steroids may cause osteoporosis and thereby causing fracture with the trivial force as well. And sometimes non-steroidal anti-inflammatory drugs that the patient has taken, they will mitigate the degree of swelling around the expected, which we expect with the fractures. What could be the symptoms? The symptoms are very similar to the acute sprains, and they are pain, swelling, deformity if it is a displaced fracture or ankle has been disorganized. There will be inability to put weight on the affected limb, and in open fractures, of course, patient may complain of bleeding of an wound. The usual format of the examination in orthopedics, you will be looking for the swelling, which will be around the ankle or around the bone which has been fractured. So say, for example, if it is the medial malleolus which has been fractured only, there will be swelling around medial malleolar area. The deformity, we will be seeing the symmetry of the ankle, the bruising and ecchymosis. Remember, all the bones here are subcutaneous, and so easily the ecchymosis comes. The muscle wasting only in the late cases is to be seen, and it will be usually in the gastrocnemius. Limb length discrepancy, there has to be a fracture in the medial malleolus, then only there will be a problem in the limb length. And we must remember the lateral malleolus tip is usually distal to the medial malleolus tip, and in displaced fracture of the fibula, it will be disturbed. When we go to palpation, temperature, we take it, and usually because of the hematoma, temperature will be raised, but it will be true only in the fresh cases. It will be normal when the patient is presenting late. There will be tenderness on the bone which has been fractured, sometimes ligaments also. It is true, the ligaments which has been ruptured, there will be tenderness over it. And usual way to do is we must palpate both malleoli, and especially the deltoid ligament. We'll come to it how to palpate in a next few slides. And we will be confirming the swelling and details of it, deformity, shortening, muscle wasting in some of the cases. What are the other structures that we want to palpate and how to palpate to rule out probability of other fractures? How to palpate talus and navicular? So idea is to locate the talar dome. We must identify the lateral malleolus and then move anteriorly from it up to the anterior recess. From here, we can move medially and anteriorly along the joint line, and the talar dome will be right beneath this point. So this is how we do it. Talus is midway between both malleoli. We start from one malleoli, usually from the lateral side, lateral malleolus, follow the joint line, and then you will find a divot. This divot is nothing but the talus. And at that time, you can evert and invert the foot to feel it more clearly. So this is how you do it. Start from one side and slowly go. And this is the place where you will find the talus. It is almost midway between the medial and the lateral malleoli, and push your finger beneath. You will find it, and invert the foot also. How to find the navicular? 2 finger breadths inferior to the medial malleolus on the anterior side. This is how you feel it. You will feel a divot like, and then this is the navicular you are feeling. And at this time, you can adduct the foot a little, it will be more prominent. 5th, metatarsal base is easily palpable. So you follow the metatarsal and the base, you can have the idea. How to palpate the cuboid? It is situated anterior to the calcaneus and posterior to the 4th and 5th metatarsal. In between this is, and you can feel it. So once you feel the base of the 5th metatarsal go posteriorly, you will feel the cuboid. Anterior joint line, how to feel for any tenderness? You have to locate the lateral malleolus, which is easily locatable, and you have to move your finger anteriorly till you find the anterior recess. So usually anterior recess, you can find it, and from this recess, keep on palpating anterior joint line medially. Neurovascular examination is very much important. You have to check for the presence and quality of the pulse of the posterior tibial artery, dorsalis pedis artery has to be ascertained by you, and then time for capillary refill also is to be assessed. It should be less than 2 seconds. Any special tests? This is one test, the squeezing of the tibia and fibula. If you do the squeezing, the pain will be produced at the fracture site. There is another one to know about the integrity of the tendo achilles, and it is squeezing the gastrocnemius will be that there will be plantar flexion of the ankle. If this is intact and if Achilles tendon is ruptured, there won't be any plantar flexion at all. We come to the classification. There are usually employed 4. The most common one I have put in the first one. Dennis Weber is the most important one, and we'll be discussing one. There could be Lodge Hansen classification. There will be anatomic description, which is usually in day-to-day practice we tell it, and then there is AO-ATA classification. Dennis Weber classification is, it is classified according to the location, the fracture of fibula, where the fibula is fractured, and its relation to the syndesmotic joint. It usually, to some degree, correlates with the need for operative stabilization and what kind of the operation we are going to perform on the patient. Fracture of the lateral malleolus and its location compared to the distal tibiofibular syndesmosis. Type A, the fracture of the fibula will be below the level of the syndesmosis. This is called infrasyndesmotic. It means the tibiofibular syndesmosis is intact, and usually the fracture is transverse. Deltoid ligament usually is intact. Medial malleus is usually fractured. It is stable when the medial malleus is not fractured. The type 2 is the fracture at the fibula is occurring at the level of the syndesmosis. This is called transsyndesmotic type of the fracture. It is usually spiral. Tibiofibular syndesmosis usually is still intact, but widening of the distal tibiofibular joint, when you give the stress to it, it means there is a syndesmotic injury. So you have to ascertain distal tibiofibular syndesmosis has been injured or it is intact. Now, Weber B fractures, they are subclassified and as isolated, associated with the medial malleolar fracture or deltoid ligament rupture, or associated with the medial lesion and fracture of the posterolateral tibia. So there are three sub-varieties. Type C, it is above the level of the syndesmosis. This is called suprasyndesmotic type of the fractures. Here, tibiofibular syndesmosis is disrupted and there will be widening of the distal tibiofibular articulation, and there will be medial malleolus fracture or deltoid ligament will be ruptured. And it is to be remembered that the fracture above the syndesmosis can happen at the neck as well. And if we know that the neck of the fibula can be involved or upper third of the fibula, it is a must for any ankle injury include whole of the tibia fibula along with the knee on the x-rays. So this is the suprasyndesmotic. So this is the syndesmosis and it is above it. And it can happen in the upper third of the fibula closer to the neck. This is part of the ankle injury. Pilon fractures. This is the fracture at the articular surfaces of the tibia, which is called tibial plafond fracture as well. So this is the Pilon fracture. You can see it. This is a fracture. X-ray has been taken. The AP view is there. And this plafond, distal articular surface of the tibia, it has been fractured. When there is a sudden load, as happens when you jump from a height, and the talus goes and hits like a hammer, and there is a plafond fracture. Now, what could be the associated injury when you find this type of the fracture on X-ray? And it is our duty as a doctor to think about it and look for other injuries. And there could be spinal compression fracture, usually found at the level of L1. There could be contralateral fracture of the calcaneum, or the similar side is the ipsilateral side. And usually there could be tibial plateau fracture, which is involving the knee joint. There is a Maisonneuve fracture that we just saw a few slides ago. It is defined as a proximal fibular fracture coexisting with a medial malleolar fracture or disruption of the deltoid ligament. When we find the Maisonneuve fracture, we know that it is associated with the partial or complete disruption of the whole of syndesmosis, which is tibiofibular syndesmosis. There will be a fracture of the medial malleolus, and then there will be widening of the tibiofibular syndesmosis. And this, when we find, it suggests that there will be a fracture in the upper third of the fibula, closer to the neck of the fibula. Tillaux fracture, it is a Salter-Harris type 3 injury of the anterolateral tibial epiphysis. This is the 11-year-old girl, and you can see it. There is a fracture of the articular surface of the tibia at the epiphysis, closer to the lateral side or extreme lateral portion of the tibial epiphysis is fractured. This is called Tillaux fracture. POTS fracture, it is also called bimalleolar fracture. It has gone the name of the POTS. And when there is both malleoli which are fractured, it is considered unstable and requires urgent orthopedic attention. There could be a name which is called cotton fracture. It is actually trimalleolar. Trimalleolar name looks funny because there is only two malleolus. There is no third. But actually, when there is a fracture, if it involves the posterior part of articular surface of the tibia, it is seen like a posterior malleolus. And then we say there are trimalleolar fracture. Differential diagnosis, foot fractures, tibia and fibula fracture, and ankle sprains. Diagnosis is usually by the X-rays, and the guidelines are very simple. The routine obtaining radiographs following an ankle injury is not cost effective. We know now by statistics that less than 15% of the patients who complains of the ankle pain after injury, they have fractures. So there is no need of getting a fracture done in every patient who complains of injury and pain. So comes the Ottawa rules. The Ottawa rules give a practical guideline when to do the X-ray, and there is another one which is called American College of Radiology appropriateness criteria for doing the X-rays. Indications are there will be bony tenderness at the distal 6 centimeter of the posterior edge of the medial malleolus or posterior edge of the lateral malleolus, same 6 centimeter, or inability to bear weight both immediately and in ED, where you are examining the patient, and is defined as 4 steps. There could be variables, and variables are if there is a neurological deficit, it is very difficult to arrive at the conclusion. Altered mental status and multi-system trauma, you cannot assess this. So this is the way we'll be doing it. Views will be taken, and there are 3 views usually advised: standard, anteroposterior, lateral, and there is mortise view. Mortise view is nothing but rotate the foot 15 degree internally and take it to get the full view of the mortise. So this is how you take it. So AP view, and this is mortise view, where all the 3 joint spaces are visualized. Their clear spaces is important for us. So how much extent of the X-ray? Full length of the tibia and fibula is to be taken to rule out Maisonneuve type of the fractures. Sometimes stress radiographs are advisable, but they are not important for the ED management. CT MRI when to do? It is not to be advised in the outpatient or the ED. Later on, we decide whether to take it or not. How to interpret the X-ray findings? The increased medial clear space should be 4 millimeter on the mortise view or stress view. So this is the medial clear space, 4 or 5 millimeter. Superior space is usually same as medial clear space, so both should be equal. And increased tibiofibular clear space. So clear space of the tibiofibular clear space is to be seen. The tibiofibular clear space 1 centimeter above the joint, it is roughly 5 millimeter or similar to on both sides. We'll see the syndesmotic injury. what will happen? There is tibio-fibular overlap, and that is to be measured in the syndesmotic injury. It is measured at the maximum overlap. There will be always overlap. Maximum overlap, it is 6 millimeter on AP view usually and 1 millimeter on mortise view. For recognizing the posterior malleolar fractures, there will be double contour sign and misty mount sign. So you can see double contour, there is one contour, again this is another fracture contour. And misty mountain, when the fracture looks like a valley and there is peak. So this looks like misty mountain sign. Tibio-fibular overlap is being seen here. What is the management? So management is simple in A&E, immobilization by POP slab or the splint, and there will be bulky padding, that is also called Jones dressing. Reduction is not advisable. You give analgesics and don't reduce the fracture, rather wait for some more time. In the case of neurovascular compromise, then only urgent reduction is advisable, and maintenance of reduction is usually by POP cast, external fixator, or internal fixation. Analgesics, there are several analgesics will be given, and then definitive treatment for different types of the fractures. For the lateral malleolar fracture, tension band wiring or screw fixation are the options available. Sometimes plates as well. So plating, lag screw, tension band wiring, all three are part of the treatment. Sometimes, not so often done, but the K wires, can you see this K wire, long K wire? Here long K wire is going. Long K wire, not usually fixes nicely, but finish the job early, people do it. Plating, it is a choice, you can do the plating. What about the medial malleolus? Fixation options, tension band wiring, cancellous lag screw, and anti-glide plate. You can see it, the screw, but this is the tension band wiring, true tension band wiring with the K wires, or only the screw fixation. Where else is the tension band wiring most commonly done? And these are patella and polycranial. What about this operative management of syndesmotic injury? We must put a syndesmotic screws. And syndesmotic screw, when you put it, patient must remain non-weight bearing, because these screws are not biomechanically strong enough to withstand the forces of ambulation. Unless you remove it, don't allow the patient to put weight, and usually it is kept for roughly 3 to 4 months. And this is the technique, we won't go in that detail. Syndesmotic injuries, see the screws put in the syndesmotic joint. What is the treatment for the bimalleolar fracture, which is also called Pott's fracture commonly? You have to fix the medial malleolus as well as the lateral malleolus. The fixation options for the lateral malleolus or the fibular fracture is open reduction and the plating, open reduction and intramedullary retrograde screw fixation, open reduction and lag screw fixation. For the medial malleolus can be cancellous lag screws, tension band wiring, or anti-glide plate fixation, usually for the vertical malleolar fractures. If there is a posterior malleolar fracture, what are the guidelines for the treatment? There could be non-operative, could be operative. The non-operative treatment is done when there is less than 25% of the articular surface is involved, or the articular step-off is less than 2 millimeter. The operative treatment, when it is decided to do, it is a screw fixation or the plate fixation. A screw fixation can be anterior to posterior. You don't open posterior side, open the anterior side, which is easy to do, and then put the lag screw where you engage the posterior malleolus. It is usually possible in undisplaced fractures. If it is displaced, it is preferable to do the posterior to anterior lag screw fixation or with a buttress plate by opening on the posterior side, can be an anti-glide plate as well. The complications could be the malunion, stiffness of the ankle, and if there is a step off at the articular surfaces, there could be post-traumatic arthritis, and there could be infections. Thank you very much.